Welcome to the third and final installment in the webinar series, Transforming Our Response, Practical Tips on Providing Trauma-Informed, Culturally Safe Care for First Nations, Inuit, and Métis women, girls, and gender diverse people. My name is Laura Bouchard. I use she and her pronouns, and I'll be your webinar moderator for today. This webinar, presented by the Native Women's Association of Canada, is hosted by the Canadian Public Health Association. Our offices are located on the original unceded territory of the Algonquin Anishinaabeg people. They've been the guardians of this land for millennia, and CPHA is grateful for the example their stewardship provides. This webinar series, brought to you in partnership by the Native Women's Association of Canada and the Canadian Public Health Association, aims to offer health and social service providers practical tips on providing trauma-informed care, specifically for Indigenous women, girls, and gender diverse people, using a case-based instruction model. Over the series of 3 webinars, we've been exploring how trauma can impact an individual's experience when accessing care, and how providers can respond to reduce barriers, improve communication, and enhance compassionate, effective care for Indigenous women, girls, and gender diverse people. So thank you for joining us today for webinar 3, the last part of the series. Recordings for webinar 1 and 2 are available on CPHA's YouTube channel if you've missed any of them live. So we're very excited to be collaborating with the Native Women's Association of Canada to put on these webinars. And the timing really could not have been better because CPHA has recently put out some new resources focusing on applying trauma and violence-informed care. These resources were produced as part of our project that centers on reducing stigma related to sexually transmitted and bloodborne infections. The TVIC toolkit, pictured on the left, supports self-reflection, organizational assessment, and monitoring and evaluation towards adopting a trauma-informed approach. In addition, an entire professional development workshop was developed in a turnkey format with all the tools to get you started on delivering training in your own workplace or region around applying the principles of trauma-informed care to reduce STDBI stigma, which is pictured on the right. You can check out our project webpage or get in touch for more information and support. And without further ado, I'd like to introduce once again our wonderful presenters. So today we're going to be hearing from Anne Seymour and Abrar Ali. Anne Seymour is an Ojibwe registered member of Wikwemikong unceded territory and is currently a PhD student at Carleton University. Her research interests include working with Indigenous communities, incorporating land-based activities to improve mental health and suicide prevention, at the same time as walking in 2 worlds. Her most recent work experience was centered on mental health, first aid, First Nations as a master trainer and co-facilitator, and healthcare in British Columbia with Fraser Health. Abrar Ali is an internationally trained physician who practiced medicine in Dubai. In Canada, Abrar provided primary healthcare on the Indigenous Reserve Akwesasne. She observed firsthand the health issues the community was grappling with and came to appreciate Indigenous culture and their holistic approach to well-being. The gaps in the healthcare system, and the health disparities that exist between Indigenous and non-Indigenous populations in Canada stimulated her desire for change. She obtained a master's in public health and has since been working for the Native Women's Association of Canada. She's passionate about equitable access to quality, culturally safe, compassionate healthcare. So thank you so much, Anne and Abrar, and I'll now hand it over to you to begin today's webinar.
Ani, thank you for the kind introduction, Laura, and welcome everyone to the final webinar of this 3-part series. Dishnaka Anne Seymour, Wikwemikong Dunjaba. My name is Anne Seymour, and I am from the Wikwemikong unceded and unsurrendered territory, located on Manitoulin Island, Ontario. My preferred pronouns are she and her. Chimigwech for taking the time to sit with us as we journey throughout this presentation, focusing on working through trauma-informed care with Indigenous people. It is my absolute pleasure to co-facilitate this session with Abrar Ali, and I'm hopeful that you will take something away from this presentation and that you won't need, and what you don't need, you can leave behind.
Thank you, Anne. Good afternoon, folks. I'm Abrar. My preferred pronouns are she and her. We're thrilled to have you join us today. We're hoping to have a fulsome discussion and welcome questions and comments from you throughout our talk. We'll be answering your questions at the end of the webinar. So as Laura mentioned, we're from the Native Women's Association of Canada, NWAC for short. NWAC is a national Indigenous organization founded on the collective goal to improve, promote, and advance the social, economic, cultural, and political well-being of First Nations, Inuit, and Métis women, girls, and gender diverse people. NWAC became a nonprofit organization in 1974 and includes 13 Indigenous women's organizations from across Canada. At NWAC, we are committed to focusing efforts on improving Indigenous health indicators and obliterating existing health disparities and negative outcomes. I'd like to take a moment to acknowledge Indigenous Services Canada, who provided the funding that made this webinar possible. In today's webinar, we'll go over a case of a rural Inuk woman. We will define trauma-informed care and discuss trauma and resilience amongst the Inuk population in Canada. We will go over the effects of trauma on clients and patients and talk about retraumatization. Finally, we'll use the case to apply the principles of trauma-informed care. Before we move on to the theoretical portion of our webinar, we want to read out a case. Now, this case is fictional and written by the authors of this webinar. Any resemblance to persons living or dead or events is purely coincidental. We encourage you to think about the elements in this case as we move forward with the theory. So Nanook is a 37-year-old Inuk woman. She and her husband have 2 children aged 2 and 4 years. She also has a 17-year-old daughter from a previous marriage. Recently, Nanook learned that she will be laid off her job as a purchaser at a busy restaurant. Shortly after, her husband left her to reconcile with his ex-wife. She also just found out that her 17-year-old daughter, Anu, is 5 months pregnant. Anu is very frightened and hasn't seen an obstetrician yet. To cope, Nanook started drinking, misusing drugs, and associating with others who were not positive influences from her earlier life. Nanook is overly stressed and wants to seek counseling. However, she's ashamed of her current situation and fears her young children will be apprehended. One evening, Nanook never came home. The next morning, neighbors noticed her young children crying at the window. Concerned, the neighbors decided to call the police. Just as the police arrived, Nanook arrived home. She was observed to be visibly disheveled and had a strong odor of alcohol. By the time Nanook was done explaining her distressing situation, Children's Aid Society arrived and determined child apprehension was necessary. They also asked Nanook to meet with a counselor to determine the next steps. Nanook has always been an ideal employee and a hardworking and dedicated mom. With the recent distressing situation of events, Nanook was overwhelmed. She promised this would not occur again and wanted to return home to Nunavut. So before we start talking further about how the counselor can provide trauma-informed care to Nanook, let's explore what trauma-informed care is. So trauma-informed care is a holistic, strength-based framework based on open-mindedness and compassion. It promotes positive health outcomes, empowerment, and healing. It's grounded in an understanding of the pervasiveness of trauma and the wide impact trauma has on an individual's physical, mental, emotional, and spiritual health. Trauma-informed care is understanding without judgment where the individual is coming from. It incorporates an awareness that individuals have different pathways to healing and utilizes various coping mechanisms to manage their trauma. It also means understanding that some may never conclude or come to a place in space where they find comfort or coping mechanisms. Trauma-informed care seeks to actively resist retraumatization and acknowledges the special needs individuals managing trauma require within the care setting, while creating opportunities for survivors to rebuild a sense of control and empowerment with a purpose to live a fulfilling life directed by them. So to understand trauma-informed care further, let's use the Substance Abuse and Mental Health Services Administration's 4 R's to trauma-informed care. The first R being realize. We need to realize the widespread impact of trauma and understand the potential paths for recovery. Trauma-informed practices are ones that are able to understand that trauma is complex and exists within all of us. They are also able to understand that there's an intersecting levels of oppression that affect certain populations more than others. They can set aside their personal beliefs, stereotypes, and opinions on marginalized populations long enough to address their needs. So let's take a step back and understand or explore what trauma is. Let's use the 3 E's to do this. The first E being events. Trauma can occur at any time in an individual's life and is often unexpected, outside the individual's control, who is often unprepared for the event. The event is often overwhelming and threatens the individual's physical, emotional, spiritual, or mental well-being. The next E is experience. An individual's experience of the event determines whether it's traumatic or not. We all experience trauma differently. What may be traumatic to one individual may not be traumatic to the other. Those that have opportunities to talk about and process the event while feeling supported are often able to integrate the experience into their lives without lasting negative effects. Nonetheless, there is no specific measure that indicates individuals are ever fully recovered from the traumatic experience. And the last E is effects. Trauma may often overwhelm an individual's capacity to cope. The individual may find ways to cope with their trauma that work in the short term, but lead to adverse physical, social, emotional, and spiritual effects in the long term. In general, trauma can be further categorized into loss, like sudden illness, death, or divorce, abuse, including physical, emotional, or sexual abuse, and chronic stressors like poverty, food insecurity, or racism. I'll now pass it along to Anne, who will speak further about the Inuit in Canada.
Thanks, Abrar. So in this slide, we're looking at who are the Inuit of Canada. As a care provider, understanding the lived experiences of the Inuit clients and patients we're working with is key and incredibly important to providing culturally safe, trauma-informed care. The Inuit are the original inhabitants of the Arctic, where they have lived for thousands of years. The Inuit have a unique culture with distinct beliefs and practices. Inuit communities have stretched from the westernmost Arctic to the eastern shores of Newfoundland and Labrador for uncounted generations. This area is known as Inuit Nunavut. It includes the communities located in the 4 Inuit regions: Nunatsiavut, covering northern coastal Labrador, Nunavut, covering the northern Quebec area, and the territory of Nunavut, and the Inuvialuit region, the Northwest Territories. In 2016, there were approximately 65,000 Inuit in Canada. Close to 3/4, 73%, lived in Inuit Nunavut, and the Inuit represent the fastest growing and youngest population in Canada. Here, we're looking at the historical trauma of the Inuit. Colonization and controlling governmental policies led to a loss of autonomy, intergenerational trauma, and acculturation. Since 1950s, the Inuit were shipped south. There was enforced killing of sled dogs. The Canadian government initiated social, economic, and cultural changes without consultation, and effects are still being felt today. Inuit children were forced to attend residential schools where there was a loss of culture and ability to parent. Here we have Inuit health comes. Compared with the population of Canada, Inuit faces challenges in terms of physical and mental health and well-being. For example, the Inuit have a shorter life expectancy and higher infant mortality rates, 12.3 versus 4.4 per 1,000, compared to the general Canadian population. In 2017, the projected life expectancy for the Inuit was 64 and 73 for males and females, respectively, compared to 80 and 84 years old for the overall Canadian population. They are always more likely to have higher rates of heart disease, respiratory illnesses, stroke, diabetes, and STDs compared to the general Canadian population. This complex multimorbidity typically occurs at younger ages. It is more severe and more likely to be complicated. Food insecurity is a well-documented problem among Inuit, where 70% of households have food insecurities. Poor housing conditions are common, where 52% of the Inuit live in crowded homes. Additionally, Inuit have some of the highest rates of TB in the world. In fact, the Inuit TB rates are 290 times that of their non-Indigenous counterparts. Despite it being preventable and curable, Inuit still die from TB today. The 4 Inuit regions in Canada have rates of suicide that range from 5 to 25 times the rate of suicide for Canada as a whole. These health disparities are a symptom of the social and economic inequities that have existed between Inuit Nunavut and most other regions of Canada since Inuit began to be impacted by colonization and the transition of the land into permanent settlements. The stress and trauma Inuit experienced during this transition, coupled with the prejudice and social inequities, led to enduring social challenges. Here we have an access to healthcare, in the north is limited, where there is only 30 physicians per 100,000 in Nunavut, compared to 119 per 100,000 in urban centers. As a result, many Inuit have to travel south to access quality healthcare for those things like childbirth and cancer care. Many Inuit are hesitant to access healthcare given their traumatic history of forced and coerced medical treatment, sudden removal and relocation, and multi-year institutionalization following a TB diagnosis. Furthermore, the Inuit not only face a geographical barrier when accessing healthcare in the south, but also face social cultural barriers. Many Inuit, specifically the older populations, are unilingual, and 70% speak Inuktitut as their first language. Many Inuit move south away from home, and this can be due to a variety of factors, including but not limited to a lack of high costs of living, lack of services, poor healthcare infrastructure, and overcrowded and inadequate housing in the north. Some Inuit may be seeking higher education or better employment. Regardless of the reason why the Inuit are moving south, there's definitely a culture shock in the urban centers. Their way of life on the land and the weather, the environment, and the elements are varied. Living in an urban center felt more like a consequence compared to a personal choice. Country foods were not available, and a lack of family supports. Indigenous people are often seen as resilient. A combination of factors supports this logic. Indigenous people have found the strength and courage to embrace their culture and retain a strong sense of identity. Further, a reclamation of their language and accessing healthy elders, traditional knowledge holders, support their desire to be healthy individuals, are being addressed daily. Indigenous people continue to live with trauma each day, and through various coping skills and supports, addressing trauma is a reality Indigenous people face. The strength and courage to embrace and rediscover culture. The culture heals and saves lives. The coping skills and support, and a strong sense of identity, a reclamation of land and language, contribute to the resiliency of Indigenous people today.
So let's go back to the 4 R's, the Substance Abuse and Mental Health Services 4 R's. Now we've already covered realize. Let's talk about the second one, recognize. We need to recognize the signs and symptoms of trauma in clients, families, and others involved within the system. This may not be easy, as everyone has different coping mechanisms and ways in which they handle and show trauma. Understanding the difference between who a person is and the symptoms or coping mechanisms that trauma can cause is important for developing a needs assessment. Now, this recognition is also important so that people's behaviors or responses aren't treated in a way that further alienates them. Anne spoke about the effects of trauma on the individual, community, and culture in past webinars, but today she's going to speak further about the effects of trauma on family as it's pertinent to the case.
So there's an increased risk of family violence, a difficulty with parenting effectively, attachment difficulties and conflictual relationships, difficulty maintaining relationships, and a loss of stories, traditions, and identity are all proven effects of trauma on the family.
So the third R, that we're going to talk about is respond. We need to respond by fully integrating knowledge about trauma into policies, procedures, and practices. Responding doesn't mean calling someone else to deal with a person because we don't have time to deal with someone who's acting in a specific way. We need to make the time and understand that every human is worth it, and meeting them where they are and safely communicating with that person on their needs in that moment. The last R is resist. We need to actively resist re-traumatization. We need to be mindful of the triggers that re-traumatize our patients or clients and communicate with them as much as possible. The key to avoiding re-traumatization is communication. Ask questions about comfort level and respect the individual's boundaries. So let's talk a little bit more about re-traumatization. An individual who's experienced trauma is vulnerable to re-traumatization. This is when a situation or an environment resembles the original trauma and triggers similar reactions experienced with the original trauma, including but not limited to fear, anxiety, terror, grief, or anger. Although often unintentional, there is a potential for re-traumatization within the care setting. Attempting to avoid re-traumatization is crucial, as individuals who are traumatized multiple times are more likely to exhibit trauma-related impacts. They are also less likely to seek and engage in treatments and interventions. Before we move on, I think it's imperative to note that healing and recovery from trauma is not linear. Survivors may be willing to participate in a treatment in one visit and not the next, and this can change from day to day and in the long term as well. Therefore, practitioners, helpers, and healers need to continuously check in with individuals and respond with empathy and understanding and adjust the treatment plan accordingly. In general, a trauma survivor must be respected for where they are in their journey. The trauma survivor takes the lead, and the helpers guide and support them along their journey. So according to the Substance Abuse and Mental Health Service Administration, the principles of trauma-informed care include trauma awareness, safety, choice, collaboration, and empowerment, strength-based, and trustworthiness. Anne and I will now go over these principles and apply them to the case we outlined in the beginning of the webinar. Anne will reread that case for you to remind you of it.
Nanook is a 37-year-old Inuk woman. She and her husband have 2 children, ages 2 and 4 years old. She also has a 17-year-old daughter from a previous marriage. Recently, Nanook learned she will be laid off from her job as a purchaser at a busy restaurant. Shortly after, her husband left her to reconcile with his ex-wife. She also just found out that her 17-year-old daughter, Anu, is 5 months pregnant. Anu is very frightened and hasn't seen an obstetrician yet. To cope, Nanook started drinking, misusing drugs, and associating with others who are not positive influences from her earlier life. Nanook is overly stressed and wants to seek counseling. However, she is ashamed by her current situation and fears her young children will be apprehended. One evening, Nanook never came home. The next morning, neighbors noticed her young children crying at the window. Concerned, the neighbors decided to call the police. Just as the police arrived, Nanook arrived home. She was observed to be visibly disheveled and had a strong odor of alcohol. By the time Nanook was done explaining her distressing situation, Children's Aid Society arrived and determined child apprehension was necessary. They also asked Nanook to meet with a counselor to determine the next steps. Nanook has always been an ideal employee, a hardworking and dedicated mom. With the recent distressing situation of events, Nanook was overwhelmed and she promised this would not occur again and wanted to return home to Nunavut.
Thanks, Anne. So now we're going to talk about the principles of trauma-informed care, and the first one being trauma awareness. Trauma-informed approaches often begin with building an awareness of the prevalence of trauma, its impacts on individuals, families, and communities, and it incorporates an understanding of the coping mechanisms individuals use to manage their trauma. Now let's look back at the case and use this to think about Nanook. In a short period of time, Nanook endured a divorce, a job loss, and her young daughter's unexpected pregnancy. Now this can be overwhelming and push her into unhealthy coping mechanisms. Please remember that trauma isn't always as evident as we've written it out in the case. Part of being trauma-informed is being aware that more often than not, the individual you're working with has experienced some kind of trauma, and as a care provider, you need to act accordingly. Now, while it might be easy to blame Nanook for going back and abusing drugs and alcohol, and some might even find her careless given that she's a mother with young children, but we need to constantly remind ourselves that drug and alcohol are actually coping mechanisms and are symptomatic of trauma. Our colleagues at Puck2T have put together the infographic that you have on the slide here. So Inuit populations have faced loss of culture and a loss of control in the past. This could lead to trauma, breakdown in families, alcohol use, drug use, and powerlessness. And that in turn leads to fear, mistrust, abuse, and denial. So if you could look at the slide here, you could see a cycle of abuse where things lead to other things and it's a continuous cycle. I really want us to focus on this cycle to understand behaviors as opposed to blaming the client.
So here we're looking at the principles of trauma-informed care, and this one is focusing on safety. So ensuring the physical and emotional safety of individuals accessing health and social services is integral to a trauma-informed care, as trauma survivors can sometimes feel unsafe with these systems. Therefore, those that are trauma-informed work towards ensuring a safer environment for the patients by adapting the physical space, providing clear information about the programming, procedure, or treatments, and ensuring informed consent and explaining predictable expectations and outcomes while ensuring privacy. In Nanook's case, she will likely feel unsafe speaking to a counselor, as the custody of her children is at stake. The counselor needs to be clear with Nanook about the nature of the appointment, what she expects of Nanook, and what are the consequences and outcomes of said appointment. A timeline of how and when her children can return to her care is especially helpful. It is important that Nanook feels supported and cared for during this time. She needs to feel like someone is advocating for her best interests, and if this individual is not the counselor should offer to have someone that is present.
So the next principle is choice, collaboration, and empowerment. Choice, collaboration, and empowerment are vital in facilitating healing and avoiding re-traumatization, as choice increases an individual's control, self-efficacy, and self-determination. This in turn improves effectiveness of services and increases an individual's willingness to engage in treatments, supports, and interventions. The counselor can establish choice by providing clear messaging about Nanook's rights and responsibilities. They can also lay out various next steps and options, educate Nanook about the details, risks, benefits, and outcomes of each one, and ask her to choose the one that best fits her needs. Transparency, while ensuring that Nanook's preferences are maintained as the end goal, are key.
The next principle is strength-based. So strength-based approaches are vital to trauma-informed care as they allow the recipients to focus and build on their strengths while empowering them to advance their resiliency and coping skills. A strength-based approach provides the opportunity for the individual to be in control of their care. Nanook clearly has many strengths. She is hardworking, she's a dedicated parent. Despite many challenges, she was able to stay employed while caring for her family. The counselor should seek out those strengths and build on them. A strength-based approach will support the individual's space and allowing for silence, time to think, and sometimes just to be. All these are critical elements to supporting the person where they're at. Trustworthiness is the final tenet of trauma-informed care. This is a big one for Nanook. Given the rightfully placed wariness between CIS and Indigenous populations, the counselor needs to work towards gaining Nanook's trust. This will not happen in a day, but rather is something the counselor needs to commit to and consistently to work towards. A provider can demonstrate trustworthiness by communicating openly, clearly, and consistently, establishing boundaries and clarifying what is expected and providing choices for treatment. Trustworthiness promotes collaboration and equalizes power imbalances and allows the expression of feelings without fear of judgment. The provider needs to meet Nanook where she is at and respect her boundaries and follow her lead. Additional tenets of trauma-informed care. Remember, working with individuals who have experienced trauma can be difficult, emotionally draining, and can lead to feelings of hopelessness, anger, and disbelief for the provider. Respect, because abuse undermines an individual's personal boundaries and autonomy. Survivors often feel diminished as human beings and may be sensitive for any hint of disrespect. Self-awareness and positionality. It is imperative that service providers are aware of their own trauma and experiences and how they relate to their beliefs, values, theories, and biases. Empathy, compassion, and active listening. Demonstrating empathy and compassion helps individuals who have experienced trauma feel supported and understood and helps create a connection. Sympathy, on the other hand, leaves survivors feeling pitied, which can create feelings of shame. Empathy can often be demonstrated when providers communicate their feelings to the patients. For example, I get the sense that you are feeling sad and hurt by what happened. Simultaneously, providers need to learn to be comfortable in silences and acknowledge that often silence is a sign of communication. Providers need to demonstrate a willingness to actively listen to recipients while showing genuine interest. This can mean paying attention to both the verbal and nonverbal cues. It's important for providers to clarify anything they are unsure of, as recipients can sometimes be vague or indirect when describing trauma. Flexibility. When working with individuals who have experienced trauma, providers need to be flexible to accommodate their needs. An example of flexibility can include a willingness to accommodate the client's difficulties with medical exams and changing normal routines or procedures, or understanding if a patient repeatedly cancels their appointment or doesn't show up. Taking time. It is important to remember that feeling genuinely heard and valued is healing, and in some cases may be the most effective intervention a clinician has to offer. Therefore, dedicating time to listen to survivors of trauma is vital. It avoids feelings of being depersonalized and devalued and enhances the senses of safety and security. And finally, a willingness to learn. It's important we learn from our care recipients we work with. Providers need to be willing to demonstrate humility and acknowledge that care recipients are experts in their own lives. Providers need to treat recipients as equals and allowing them the opportunity to express themselves while highlighting their strengths. Collaborating with recipients and demonstrating a willingness to learn improves the quality of care. Failing to do so will reinforce power imbalances, make the recipients feel weak, inferior, and may risk triggering emotions of the original trauma.
So before moving on to our last exercise, we want to take a moment to talk about communication. Effectively communicating with patients and clients is key to trauma-informed care, as without communication, consent, choice, collaboration, and trust are impossible. As we mentioned in previous slides, communication with Inuit patients and clients can be challenging given the language barrier. Additionally, as demonstrated in this slide, challenges with terminology also exist. There are still no words in Inuktitut for many sexually transmitted infections, for example. This can contribute to difficulty educating, diagnosing, and treating. Our colleagues at Puktitut have released a glossary on sexual health where they attempted to translate words into various dialects of Inuktitut. We've captured some screenshots of this glossary to illustrate the complexity of the language. What we want you to take home from this slide is that communication can be difficult, but if you put the effort and do your research, you can mitigate this challenge. So before we end today, we want to do one last exercise. Anne and I will present different scenarios, and we encourage you to think about how to explain this individual's behavior in a trauma-informed way. So let's try to think, is this a difficult patient or is this a coping mechanism? Now, in the first scenario, the person is uncooperative, non-compliant, and treatment resistant. Now, you might immediately think that this person's being difficult, rude, or maybe they're just a careless person. But let's try to think about a trauma-informed explanation. Anne, what are your thoughts? I'll fill in for Anne here.
This could be a flight reaction where the patient is disengaging or disassociating or withdrawing.
Thanks, Anne. So in the next scenario, the patient is consistently missing or canceling appointments. Now, this person may appear to be irresponsible, careless, or just doesn't respect your time. But let's take a moment to think, is there more beneath the surface? Anne, what do you think?
The individual may consistently miss or cancel appointments.
And this could be a flight reaction. So the individual is passive and disengaged, and they might be punishing themselves. In the next scenario, the individual is exhibiting signs of drug withdrawal. They appear to be sweating, nauseous, jittery, and irritable. Now, you may be thinking that this person is on something, or you might be wondering what kind of drugs they're taking. But let's try to come up with a drug-free, trauma-informed explanation for their behavior. Anne, how do you feel about the case?
In this situation, the individual may be exhibiting physical effects of trauma.
I agree, or they might be triggered and exhibiting retraumatization. Now, in the last case, the individual is unmotivated and passive. And you might think, well, this person is zoned out, they're careless, and maybe they're just all around difficult. But maybe there's an explanation to their behavior. What are your feelings, Anne?
The individual may be having a freeze reaction. An individual is giving in to those in power.
Well, today we went over a case of a rural Inuk woman. We defined trauma and discussed trauma and resilience amongst the Inuit in Canada. We spoke about retraumatization, defined trauma-informed care, and used the case to apply the principles of trauma-informed care. We sincerely hope you found the webinar informative. We want to take a moment to thank the Canadian Public Health Association for partnering with us on this webinar and give a special shout out to Laura Bouchard and Shireen Noble. Finally, we want to thank you. Thank you for taking the time and giving us your attention today. We look forward to answering any questions you may have.
Thanks so much, Anne Lebrar, for another really informative and thought-provoking presentation. And we do have some time for questions. So as we have before, we invite anyone that has questions for Anne Lebrar to type them using the Q&A function from the menu on Zoom there. And we'll spend some time going through those. It is also a beautiful, sunny Friday afternoon, so we'll see if we have any questions coming in. Oh, here we go. Okay. So we have, why are the Inuit people more susceptible to all those illnesses, such as diabetes, heart disease, etc.?
That's an excellent question, Kathy, and thanks for it. So the Inuit are susceptible to these illnesses as they are susceptible to negative social determinants of health. So recent studies have shown that if you live in poverty, if you live in overcrowded homes, if you have food insecurity, you're more susceptible to these illnesses. Keep in mind that the Inuit have less employment opportunities, have lower education levels, tend to have lower education levels, and live in environments where food and supplies are extremely expensive. So they may be relying on less healthy options to eat. The other thing to think about is historically, the Inuit population lived off of the land. So they hunted and they gathered for their food and they conducted a lot of activities. Due to forced relocations, they're not allowed to conduct, or it's not that they're not allowed, they're unable to conduct these activities anymore. And they have to rely on a completely different culture than what they're used to or what they're programmed to do. All of these collectively increases a person's susceptibility to chronic illnesses. The other thing I wanted to add just really quickly is trauma in and of itself puts a person at an increased risk of chronic illnesses. And as we demonstrated in the presentation today, they've been through their fair share of trauma.
Thanks so much, Abrar. We have another one that's come in here. What is the best way to be mindful of trauma responses in the moment? How can you remind yourself as a therapist to always have this lens on?
I really appreciate that question because I'm also a provider on the front lines, and I find that sometimes, especially during busy days or long days, it's easy to forget and to blame the patient for a certain behavior or aspect in their behavior. And I find that, you know, with trial and with consistent reminders, it becomes a part of who you are. So I don't think you should expect yourself, it's unfair to yourself to expect yourself to transform your response in one day, but rather it's something that you want to do every day and position yourself. So, you know, every time a patient comes into your office or leaves, just try to position yourself and center your thoughts and try to push the stereotypes out and open your mind for understanding. What I find, what I do when I have clients, I usually try to think kind of like what we did in the exercise earlier. Instead of leaning towards the, well, for lack of a better term, I'll say obvious explanation for their behavior, I try to search for a trauma-informed one. The other thing I like to remind myself is trauma literally exists in all of us, in different levels, in different proportions, but each and every person is carrying something with them. And once you realize that, you can start to come up with more trauma-informed explanations to trauma responses.
That's really great. Thank you so much, Abrar. We do have a couple of more here. So we have, does one ever fully heal from trauma?
That's a fantastic question. And what I can tell you is nobody really knows. So as we mentioned, there's no measure to explore whether a person is fully healed from trauma. A person can live for years without thinking about their trauma or even exhibiting symptoms about it. And then maybe suddenly one day something happens and it comes up. So the key to healing from trauma is to seek supports. So if you've ever been through something in your life, find a counselor, find a friend, rely on your social support networks to overcome this trauma, because studies have shown that people who have the supports are more likely not to exhibit symptoms or effects of trauma.
Okay. Another one we have here. What are some ways to increase safety in a clinic setting?
Another great question. So in my opinion, I think if we're going to boil it down to one sentence, it would be communication. You want to talk with your clients, you want to make, or your patients, you want to make sure that they're comfortable, that they're feeling safe, and if not, adjust accordingly. The beauty about the human race is that we're each different. And that also makes it complicated when we deal with a group of people, because I might perceive a certain environment to be extremely safe while another person won't. So the key is to continuously communicate with everybody, read the verbal and the nonverbal cues. So if you have a client coming in exhibiting, being withdrawn, you might start to think there's something underneath the surface there. In the meantime, things that help everybody is to provide information in written form, maybe have a video playing consistently and constantly. Be very open about what is expected out of this appointment. Now, I know that we're in a society, or we're in a time where we don't have as much time as we would like to provide or dedicate to our clients. And what you can do is just be upfront about that. Welcome to the clinic. We've got 15 minutes. Today, I expect this of you. This is what I expect the outcome to be. What do you expect of me? Pulling it back to them, what do you expect from me, really helps because it centers them. And they realize that this appointment is about them and not about you. And really, it's things like that that would really help promote the safety.
Great. Thank you so much, Abrar. I would put a shameless plug in here as well for our trauma and violence informed care toolkit that CPHA has put out. If you're kind of looking, again, for some of these ideas about kind of tangible things you can do that, to increase safety in your service setting. We do have an organizational assessment tool that also goes through a lot of similar recommendations to what Abrar has just kind of laid out. And I think it's about a 30 item assessment toolkit. So if you haven't had a chance to take a look at that, that might also be an interesting resource for folks who are looking at kind of some tangible ways to hopefully increase safety in their service settings. We do have a couple more questions that have come through. Does the Inuit culture relate to the two-spirit concept? And what are the general views on sexuality or homosexuality? Is there a relationship with this to STBBIs? Interesting question.
It really is an interesting question. Unfortunately, I'm not an Inuit woman, so off the top of my head, I can't answer this question, and I definitely would not be able to do it justice. But if you give me time, I could actually do the research, Kathy, and I'll send you the answer, because off the top of my head, I'm actually not quite sure.
Awesome, thanks, Abrar. Are there particular nonverbal cues exhibited by Inuit people?
That's another great question. So here's how I feel towards verbal and nonverbal cues. I find them highly individualistic. So while a person might exhibit being withdrawn, avoiding eye contact, looking away, another person might be able to mask those feelings a lot better, and they'll be able to actually appear almost happy or almost okay during the interaction. So I find it to be extremely individualistic, but at the same time, there are certain things that you can look out for. Some of them being, avoiding eye contact, refusing to answer questions, being silent a lot of the time, being abrupt with you. Don't forget that being aggressive and angry is also a trauma response. Again, if we go back to the exercises that we did in the beginning, all of those include nonverbal cues, maybe jittering, you find a rapid heart rate, a high blood pressure. All of these things are, could be potentially red flags to somebody who's reacting to trauma.
Thanks so much, Abrar. Yeah, I think that's a really great response to that question. And I really love what you kind of said there around how individual I think these nonverbal cues can be. And maybe something is to name what you're noticing or seeing in someone's nonverbal cues and sort of try and ask or explore what they might be feeling if you're sensing discomfort. Might be another another kind of approach to that.
Absolutely.
As well. Well, really great questions. There's one more in here. Maybe we'll tackle this one, and if none else come through, we can maybe call it a day there. So the comment here is, I love how passionate you both are about trauma and violence-informed care for Indigenous populations. Thanks so much. I've loved this series. As an uninvited settler on Indigenous lands, what are some of your best suggestions for ways to increase trauma-informed care in rural communities where Indigenous populations often reside, specifically with sexual abuse, without suffering from the dreaded white knight syndrome?
Alyssa, I can't tell you how much your question resonates with me. I'm definitely an uninvited settler on Indigenous lands. And one of the first things I do is position myself and recognize that that is who I am. I'm also very upfront when working with Indigenous populations, and I always make sure that I'm actually invited into the circles. And invited to the conversation and the discussion. And I've been very fortunate thus far where I've always been welcome to the table, but that's something I always make sure to take permission for. And I position myself very clearly that I'm a non-Indigenous woman who doesn't pretend to know the experiences of Indigenous people as I've never lived them. On the other hand, I think listening is very important. So, you know, that thing that your grandma always tells you, you have 2 ears and 1 mouth for a reason, that is very big. I think when working with Indigenous groups, you have to listen, you have to observe. And like we discussed earlier, you got to look for verbal and nonverbal cues. And to answer your question about trauma-informed care within communities, it's just give it back to the population. Let them tell you what they need and follow their lead. It's not that, like you said, the whole white knight syndrome, I completely agree with that. It's not that I'm here to help you, it's I'm here to learn from you. I'm here to see, you know, what you have to give. And you'll find that more often than not, populations and people know exactly what they want, which is not surprising. They've lived for millennia, you know, surviving and thriving before any involvement from any outside forces. And so it's just listen and follow their leads. And if I can just do one shameless plug, like Laura was saying, it's follow the principles for trauma-informed care, the ones that we highlighted. And if you do, in general, wherever you go, you'll find that you're doing the right thing.
I think just to add on to that, Abrar, I think like your responses are absolutely amazing. I think it's just great. So just to add on to that, I think it's important that learn about the communities that you are working with. So you want to be able to find out what are their traditions, what are their values, are there any ceremonies or any practices that they do have. So the more information and knowledge you have about the community you're working with and the people, and you learn about their traumas. Some communities may be fly-in, some may be remote. The northern communities have different environmental impacts, and what kind of stressors and environmental stressors are there. And so what may be traumatic to one community may not be as traumatic to the next, or maybe everyone has experienced traumatic situations. So it's important to be knowledgeable about the traumas that you're coming into.
Absolutely. Yeah. So you'll find that communities are experts in their lives, which is not shocking when you say it out loud, but it sometimes needs to be said.
Fantastic. These are really great questions and really, really great and thought-provoking answers. So thanks for taking the time to kind of continue this dialogue. It does look like there's kind of a comment here stemming back to the question around Two-Spirit in Inuit communities. So I'll just share this, and there's a link here that I'll also put in the chat box for everyone to see. So the comment is, I'm an Inuit woman from Labrador, not Nunatsiavut, who identifies as Two-Spirit. And while it's not the term that I've found within my culture, it is a term I most connect with. There is a great documentary called Two Soft Things, Two Hard Things that is Inuit sexuality gender specific. So that's great. I'll post the link that was offered here right into the chat for any folks that are interested in checking that out.
Thank you for that, Denise.
And again, I'll send this link as well in the sorry, typing and speaking at the same time in the email that will follow the webinar. Just so if anyone misses it right now, we'll make sure that we send that link in the follow-up as well. And another comment in here, we also need to follow our traditional teachings that have always guided us. So yeah, really, really great great questions and comments, and really we appreciate so much those who have contributed to this webinar series by participating and engaging in the Q&A period, you know, today or throughout the webinar series. We really do, yeah, it's been a great experience, and we really appreciate your engagement. So with that, it looks like we're kind of through with the questions. So let's get this link in here. Okay, there we go. There's the link for that documentary in the chat there. And yeah, with that, I'll just say thanks again to Anne and Abrar for all of your hard work in preparing and presenting these webinars and being able to provide this really enriching experience over the last few weeks. So thank you so much. And thanks to all of you for participating today and for the entirety of the webinar series.